Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 334 of our pharmacotherapy series, which majors in diabetes mellitus. The first question relates to patient LSK from part 333 of this pharmacotherapy series. Should LSK be treated with drug therapy for his dyslipidemia? The ACC/AHA made important changes in the management of dyslipidemia regarding cholesterol management recommendations. Although the previous ATP3 guidelines focused on specific LDL and non-HDL cholesterol target goals, the new guidelines recommend initiating statin therapy based on cardiovascular risk. Cardiovascular risk is determined by age, comorbidities, lipid panel, social, and family history. The ACC/AHA guidelines recommend a moderate-intensity statin for diabetics between the ages of 40 to 75 with LDL between 70 and 189 mg per deciliter with estimated 10-year atherosclerotic cardiovascular disease risk abbreviated as ASCVD risk is 7.5%. All patients between the ages of 40 to 75 are recommended a high-intensity statin if they have had a clinical atherosclerotic cardiovascular disease, including coronary heart disease, myocardial infarction, stable angina, stroke, transient ischemic attack, or peripheral arterial disease. Patients greater than the age of 75 are generally recommended to be initiated on a moderate-intensity statin due to risk of myalgias. Diet and exercise are cornerstones in the management of dyslipidemia in patients such as LSK. Weight loss is associated with improvements in insulin sensitivity and glucose control, as well as a reduction in triglycerides, total cholesterol, and LDL cholesterol. Physical activity enhances weight loss and increases HDL cholesterol levels. Thus, LSK's diet and exercise habits should be reassessed, and instruction in both should be reinforced as appropriate. Because insulin resistance may be the underlying cause of elevated lipids in these patients, efforts should be devoted to reversing insulin resistance as well. Given LSK's age and risk factors, a statin is indicated. The next question reads, LSK is referred to the ophthalmologist for his persistent complaints of vision problems despite improvement in his glycemic control. He is diagnosed with mild background retinopathy. Should LSK be concerned? Ocular disorders related to diabetes are the leading cause of new cases of legal blindness in Americans. Patients with diabetes mellitus may experience blurred vision associated with poor glycemic control, but retinopathy, senile-type cataracts, and glaucoma are the complications that threaten sight. Diabetic retinopathy appears as early as 3 years after diagnosis and is evident in 90% of type 1 diabetic individuals after 15 years. Comparable figures for patients with type 2 diabetes mellitus treated with insulin and for those treated with diet and oral agents are 80% and 55%, respectively. Proliferative retinopathy is less prevalent, but nevertheless is present in 30% of people with type 1 diabetes mellitus and in 10% to 15% of insulin-treated patients with type 2 diabetes mellitus who have had diabetes for 15 years or longer. Patients with type 1 diabetes mellitus should have a dilated retinal examination within 5 years of diagnosis. Evaluation is not necessary before 10 years of age. Patients with type 2 diabetes mellitus should have a comprehensive eye examination soon after diagnosis. The ADA recommends annual comprehensive eye examinations. Less frequent eye examinations, every 2 to 3 years, can be considered in patients with normal examinations based on the advice of an ophthalmologist. Current theories addressing the possible causes of this complication have been thoroughly reviewed. Microvascular disease characterized by thickening of the capillary membrane may be the underlying lesion for two forms of retinopathy. The first and most common presentation is a non-proliferative retinopathy, which is characterized by microneures MS that may progress to hard, yellow exudates, signifying chronic leakage, retinal edema, and punctate hemorrhage. This form of retinopathy may be associated with loss of central vision, but generally is associated with excellent visual prognosis. Focal laser photocoagulation of the retina in patients with non-proliferative diabetic retinopathy and macular edema decreases the likelihood of visual loss by 50%. A second, less common presentation is proliferative retinopathy. This form is characterized by neovascularization, presumably owing to retinal hypoxia. Neovascularization ultimately leads to fibrosis, vitreous hemorrhage, and retinal detachment. Photocoagulation therapy may arrest progression and decrease loss of vision associated with neovascularization. Because hypertension, smoking, uremia, and hyperglycemia may lead to more rapid progression of the retinopathy, every effort should be made to eliminate these risk factors for LSK. The ACCORD study assessed the impact of intensive glycemic, BP, and lipid control on the progression of retinopathy. After 4 years, the rates of progression of diabetic retinopathy were reduced with intensive glycemic control, 7.3% versus 10.4% with standard therapy, and also with fenofibrate, 6.5% versus 10.2% with standard therapy of just a statin alone. Somewhat surprisingly, intensive BP control did not have an effect, 10.4% versus 8.8% with standard therapy. However, on closer interpretation, this finding makes sense as the BP in the standard therapy group achieved excellent control, that is 133.5 mm of mercury, so further lowering the BP, that is 119.3 mm of mercury in the intensive group, did not provide additional benefit in reducing the rate of retinopathy progression. The next question reads, should LSK be started on aspirin therapy? The issue of aspirin use for primary prevention continues to be debated. The ADA recommends aspirin therapy as secondary prevention in patients with a history of cardiovascular disease, e.g., myocardial infarction, vascular bypass procedure, peripheral vascular disease, stroke or transient ischemic attack, claudication, or angina. Primary prevention is indicated in diabetic individuals who have a significant risk of cardiovascular disease events, 10-year risk greater than 10%. Although the ADA lists several risk calculators that can be used in patients with diabetes, the UKPDS calculator can be downloaded and is relatively easy to use. http://www.dtu.ox.ag.uk/riskengine/closing parenthesis. In patients with a very low risk, 10-year risk 80 years of age. Newer studies have shown antiplatelet therapy renders this patient population to increased incidences of bleeding without significant reduction in cardiovascular disease events. LSK has several cardiovascular risk factors, such as albuminuria, dyslipidemia, hypertension, obesity, and age, and should be started on aspirin therapy as primary prevention. LSK should take an enteric-coated aspirin, 81 mg daily. Although some authors have suggested that higher doses of aspirin should be used because of the increased platelet reactivity that can be seen in people with diabetes, the clinical literature does not support this approach and the ADA does not recommend doses greater than 162 mg daily. The next question reads, HDD is a 36-year-old man with a 20-year history of type 1 diabetes mellitus. He has poor glycemic control, A1C of 12%, and complains of frequent, severe hypoglycemic reactions that don't make sense. According to HDD, I have insulin reactions right after I eat, but later on, my glucose concentrations are sky high. HDD presents to the diabetes clinic with a 2-month history of nausea, postprandial fullness, early satiety, and occasional vomiting, all of which are unrelieved by antacids. HDD also has peripheral neuropathy involving both his hands and feet and manifestations of autonomic neuropathy, impotence and orthostatic hypotension. An upper GI series was ordered to rule out peptic ulcer disease and gastroesophageal reflux disease, and a solid meal, gastric emptying study using scintigraphy indicates the diagnosis of diabetic gastroparesis. What is the cause of diabetic gastroparesis? How should HDD be treated? Autonomic neuropathy may present as gastroparesis with feelings of bloating and nausea, urinary retention, impotence in men, manifested as retrograde ejaculation or an inability to attain an erection, postural hypotension, tachycardia, and diarrhea with incontinence of stool. The presence of autonomic insufficiency may have profound effects on the patient's response to vasodilating drugs and ability to counteract hypoglycemia. Poor glycemic control with unexplained hypoglycemia may result from the disrupted delivery of food to the intestine, that is, glucose delivery does not correspond with prandial insulin action. As a result, the blood glucose levels can fluctuate greatly. Many patients with diabetic gastroparesis, like HDD, have had diabetes for many years and also have evidence of peripheral and autonomic neuropathies. Conventional antiemetic therapy is usually not helpful in the treatment of gastroparesis. Prokinetic agents, such as metoclopramide, are considered first-line therapy. Metoclopramide increases gut motility through indirect cholinergic stimulation of the gut muscle. However, symptomatic improvement does not always correlate with improved gastric emptying, which implies that the effectiveness of metoclopramide also is related to its centrally mediated antiemetic activity. The usual starting dose of metoclopramide is 10 mg orally 4 times daily, 30 minutes before meals and at bedtime. Although treatment may not eliminate all symptoms, it should minimize most of the patient's complaints. Patients should be monitored for tardive dyskinesia, a potentially irreversible and disfiguring condition that is characterized by involuntary movements of the tongue, face, or extremities. In 2009, the FDA added tardive dyskinesia as a black box warning for metoclopramide. The risk of tardive dyskinesia increases with the duration of treatment and the total cumulative dose. Other pharmacotherapeutic interventions include domperidone, cisapride, erythromycin, and cholinergic agonists. A key component to treating HDD's gastroparesis is improving his glycemic control. Also, HDD should be advised to try eating smaller, more frequent meals and to chew his food well. This of course will require adjustments to his prandial insulin therapy. Also, eating a low-fiber and low-fat diet may help with his symptoms. The next question reads, 6 months after institution of metoclopramide 10 mg 4 times daily and several insulin adjustments, HDD's GI symptoms have been alleviated, and his diabetes mellitus is now reasonably well controlled as evidenced by elimination of hypoglycemic episodes and a recent A1C of 7.5%. However, HDD has been complaining of increasing bilateral foot pain, which he describes as a burning, tingling, or prickly sensation. An examination of his feet reveals cool extremities with absent pulses, reduced vibration perception, and loss of 10G monofilament pressure sensation. What are appropriate steps that can be taken to alleviate HDD's peripheral neuropathy? Diabetic neuropathy may be a consequence of metabolic disturbances in the neurons, microangiopathy affecting the capillary supply to neurons, or an autoimmune process. It affects 60% to 70% of the diabetic population and has a broad spectrum of presentation. Clinically, it most commonly presents as a diffuse symmetric sensory motor syndrome, as carpal tunnel syndrome, or as autonomic neuropathy, e.g., tachycardia or orthostatic hypotension caused by cardiovascular autonomic neuropathy. Symptomatic diabetic peripheral neuropathy occurs in 25% of patients with diabetes. It is characterized by paresthesia and pain in the lower extremities that may be mild or severe and unrelenting, decreased sensation to monofilament testing, decreased ankle and knee jerks, and decreased nerve conduction velocity. The decreased sensation associated with peripheral neuropathy contributes to the progression of foot injuries and infections that may go unnoticed by the patient until they are severe. The management of diabetic neuropathies has been reviewed. To view a video of how to perform a complete foot examination, see http://www.medscape.com/viewarticle/708703. Pharmacologic management consists of symptomatic therapies. Painful neuropathy may respond to simple analgesics, e.g., acetaminophen, or nonsteroidal anti-inflammatory drugs. The analgesics selected should be based on the patient's history of responsiveness to these agents as well as their duration of action and side effect profiles. Side effects include GI upset and bleeding, and renal and hepatic toxicity. Avoid chronic nonsteroidal anti-inflammatory drug use owing to their renal toxicity and development of GI ulcers. Other pharmacologic options include tricyclic antidepressants, abbreviated as TCAs, duloxetine, a serotonin and norepinephrine reuptake inhibitor, gabapentin, pregabalin, and other anticonvulsants, e.g. carbamazepine, lamotrigine, topiramate, and oxcarbazepine. Only pregabalin and duloxetine have the FDA indication for the treatment of diabetic peripheral neuropathy, others are off-label. Efficacy, side effects, drug interactions, renal and hepatic function, and cost should all be considered when an agent is chosen. Often less expensive options are tried first, off-label such as gabapentin or tricyclic antidepressants. Topical application of 0.075% capsaicin has been recommended for diabetic neuropathy but may take several weeks to work. Lidocaine 5% patches have also been used. These may be helpful in patients intolerant to oral medications. These may be used in combination with oral medications. Tramadol or opiates may also be used second line. The next question reads, can anything be done for HDD's peripheral vascular disease? Peripheral vascular disease or peripheral arterial disease presents as diminished or absent foot pulses, intermittent claudication, skin ulcers, gangrene, or amputation. People with diabetes are 2 to 10 times more likely to experience symptoms of peripheral arterial disease than those without diabetes, and half of all non-traumatic amputations in the United States are performed in patients with diabetes. In one study that followed type 2 patients for 7 years, 5.5% had an amputation. The prevalence of this condition increases with age, duration of diabetes, and the presence of risk factors such as hypertension or smoking. Signs and symptoms of peripheral arterial disease include leg pain, which is relieved by rest, cold feet, nocturnal leg pain, which is relieved by dangling the feet over the bed or walking, absent pulses, loss of hair on the foot and toes, and gangrene. Treatment of this condition includes elimination and treatment of risk factors such as smoking, dyslipidemia, hypertension, and hyperglycemia, antiplatelet therapy, exercise, which is the mainstay of therapy, and revascularization surgery. HDD should be thoroughly educated regarding proper foot care, perform daily self-foot examinations, and receive regular care by a podiatrist. The next question reads, PAL, a 37-year-old obese woman with systemic lupus erythematosus, has been taking 60 mg per day of prednisone for 6 months. During this period, her weight has increased by 30 pounds and she has experienced glycosuria with no ketones. Her primary provider asked her to start self-monitoring of blood glucose. She was referred to the diabetes clinic, where her pre-dinner and bedtime blood glucose values were found to be 140 to 160 mg per deciliter and fasting plasma glucose values were 80 to 105 mg per deciliter. Physical examination shows a 5 feet 2 inch (150 pound) depressed woman with truncal obesity and an acneiform rash. Her mother and one sister have type 2 diabetes mellitus. How do corticosteroids contribute to diabetes mellitus? How should PAL be treated? The term steroid diabetes was first used to describe the hyperglycemia and glycosuria seen in patients with Cushing syndrome. Now, it is associated more commonly with exogenously administered glucocorticoids and has been a side effect of parenteral, oral, and even topical therapy. Corticosteroids are one of the most common drug groups that unmask latent diabetes or aggravate pre-existing disease, and they may produce hyperglycemia and overt diabetes in individuals who are not otherwise predisposed. Corticosteroids increase hepatic gluconeogenesis, suppress insulin secretion, and decrease tissue responsiveness to insulin. The primary effect is impaired glucose disposal after meals, resulting in daytime hyperglycemia, and by morning, the glucose levels normalize. Although steroid-induced diabetes generally is mild and rarely associated with ketonemia, a wide spectrum of severity may be encountered, from asymptomatic, abnormal glucose tolerance tests to difficult-to-control, insulin-requiring disease. The onset of glucose tolerance can occur within hours to days or after months to years of chronic therapy. The effect generally is considered dose-dependent and usually is reversible on discontinuation of the drug. PAL exhibits many symptoms that can be attributed to supraphysiologic doses of corticosteroids, truncal obesity, depression, acneiform rash, and diabetes. Mildly elevated glucose levels in obese individuals, as in PAL's case, sometimes can be controlled by diet, but may require treatment with a short-acting insulin secretagogue or rapid-acting insulin before meals. A person with diabetes whose blood glucose is increased by use of a glucocorticoid should modify treatment appropriately to restore glycemic control. It is important to anticipate the need to modify insulin or other antidiabetic therapy because corticosteroid doses are increased or decreased. The next question reads, CRC, a 41-year-old man with type 1 diabetes mellitus, is well controlled on a basal bolus insulin regimen and has been taking pseudoephedrine 30 mg 4 times daily for 7 days and Robitussin DM 10 ml 4 times daily, which contains 2.92 grams of sugar per 5 ml, for a cold. Recently, glucose concentrations have been higher than usual. Can pseudoephedrine or the cough preparation be the cause of his poor glycemic control? Discuss the use of sympathomimetics and cough preparations in patients with diabetes. Over-the-counter drug products, such as decongestants and diet aids, which contain sympathomimetics, carry warning labels that caution against their use in patients with diabetes mellitus. Standard sugar and ethanol-containing cough preparations also carry such warning labels. However, clinically significant drug-induced glucose intolerance probably is very infrequent. It is well established that parenterally administered epinephrine increases blood glucose concentrations secondary to increased glycogenolysis and gluconeogenesis. Other sympathomimetics generally do not have as potent an effect on blood glucose as epinephrine, and their use usually does not pose a practical problem in diabetic patients. Furthermore, the effects of sympathomimetics on BP must be considered in many patients with diabetes. Therefore, antihistamines or occasional use of nasal sprays for severe congestion may be needed. In summary, pseudoephedrine or the cough preparation may be aggravating CRC's glycemic control, although at these low to normal therapeutic doses, it is quite unlikely. The stress related to CRC's underlying cold is more likely to be impairing his glucose tolerance than these low doses of sympathomimetic agents or the small amounts of sugar contained in the cough syrup. The next question reads, KCF, a 22-year-old woman with newly diagnosed type 1 diabetes mellitus, enjoys a glass or two of wine with her evening meal. What effect does alcohol have on a patient with diabetes, particularly one using insulin? Is alcohol contraindicated in KCF or any person with diabetes mellitus? Clinicians often are reluctant to permit the use of alcoholic beverages in patients with diabetes mellitus. However, barring contraindications that are similar in the non-diabetic and diabetic patient alike, e.g., alcoholism, hypertriglyceridemia, gastritis, pancreatitis, pregnancy, a person with diabetes can safely enjoy a moderate alcohol intake as long as certain precautions are taken. For an in-depth discussion, the reader is referred to 2 comprehensive reviews of alcohol and diabetes, parts of which are summarized in the following list. Drink in moderation. The ADA defines this as a daily intake of 1 drink for adult women and 2 drinks for adult men. 1 drink is defined as 5 ounces of wine, 12 ounces of beer, or 1.5 ounces of distilled liquor. The patient should be aware of his or her own sensitivity to the intoxicating effects of ethanol and adjust consumption downward, if needed. This is particularly important for insulin-dependent patients. When having a drink, be sure to have it with a carbohydrate-containing meal. Avoid drinks that contain large amounts of sugar, such as liqueurs, sweet wines, and sugar-containing mixers. Instead, consider dry wines, light beers, and distilled spirits. Not only does the simple sugar content add an additional source of glucose and calories to the diet, but ethanol ingested with simple sugar-containing mixes enhances reactive hyperglycemia. Remember to count the calories in alcohol. Calories equals 0.8 multiplied by proof multiplied by ounces. Substitute 1 ounce of alcohol for 2 fat exchanges. Be aware that the symptoms of alcohol intoxication and hypoglycemia are similar. If hypoglycemia is mistaken for intoxication by others, appropriate and potentially life-saving treatment can be delayed. Be aware of alcohol-sulfonylurea drug interactions, specifically the alcohol-induced enzyme induction of tolbutamide metabolism and the chlorpropamide alcohol flush reaction. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 335.